Everyone, so we are starting with neurology. Just need, sorry, 29. Restricted textbook of pediatrics, features of neurological disorders in children. Recurrent headache are often caused by migraine or tension type headache. Febrile seizures are common and usually have a good prognosis, but any treatable cause of febrile illness needs to be identified. Diagnosis of an epilepsy is primarily based on a detailed history and is often substantiated by video. Epilepsy syndromes present at different ages. An infant has less than 4 to 6 months. Childhood access epilepsy at 4 to 12 years. Motor disorders may be central involving the spinal pyramid, in fact, basal ganglia cerebral, peripheral neuromuscular disorders. The number of babies born with neurotrophic defects has declined markedly in the last years. Central nervous system comprised of 1 lakh million neurons, and when multifunction has potentially generate a wide spectrum of clinical problems. The signal dysfunction neurons determines the nature of the problem, which may involve impaired movement, vision, hearing, sensory perception, learning, memory, consciousness, or see this generate neurological as well as emotional affective disorders, anxiety, depression, other mental health disorders, some functional medically unexplained illnesses. Division of the brain disorders into neurological and mental health is artificial. And although based historically on morbid pathology, is nowadays more based on the therapies often than on biology. Classifying this wide range of symptoms complexes can be problematic. Headache is a frequent reason for children and adolescents to consult a doctor. International Headache Society has advised the classification. Primary headache, 4 main groups comprising migraine, tension type headache, cluster headache, and other primary headaches such as primary stabbing headache. They are thought to be due to primary malfunction of neurons and their network. Secondary headache, symptomatic of some underlying pathology from raised intracranial pressure or space occupying lesions, trigeminal, and other cranial neuralgias and other headaches, including root pain from the herpes. Exhaustive primary headache, tension type headache. This is symptomatic headache of gradual onset of described as tightness, a band of pressure. There are usually no other symptoms migraine without, or this accounts for 90% migraine treated episodes will last 1 to 72 hours. The headache is commonly bilateral but not unilateral. Characteristically versatile over the temporal frontal area. It is often accompanied by unpleasant GI disturbances, such as is such as nausea, vomiting, abdominal pain, photophobia, and phonophobia. Sensitivity sound is typically aggravated by physical activity relieved by sleep, migraine with aura. This accounts for 10% of migraine. The headache is preceded by unilateral aura, visual, sensory, or motor impairment. Although the aura may occur without a headache, features are the absence of problems between episodes and the frequent presence of premonitory symptoms, tiredness, difficulty concentrating, autonomic features. The most common aura comprises visual disturbances, which may include negative phenomena such as hemianopia, loss of half the visual field, or scotoma, small areas of vision loss. Positive phenomena such as fortification spectra, seeing zigzag lines, really they are unilateral sensory motor symptoms like PJ migraine symptoms of tension type headache or migraine offer overlaps. They are probably part of the same pathophysiological continuum, with evidence that both result from primary neuronal dysfunctions, including channelopathies with vascular phenomena as secondary events. There is a genetic predisposition. First degree and secondary relatives often also affected. Bouts are often triggered by a disturbance of inherent biorhythms such as late nights or early rising stress, or winding down after stress at home or school. Certain food, cheese, chocolate, and caffeine are only really a reliable trigger. Influence headache can be related to menstruation, the oral distance. Okay, and then uncommon forms of migraine this include familial hemiplegic migraine caused by cultural channel effect, dominantly inherited, sporadic hemiplegic migraine, migraine with brainstem aura, vomiting, nystagmus, or cerebellar signs. Periodic syndromes, often precursors of migraine, include cyclic vomiting, recurrent stereotyped episodes of vomiting, and intense nausea associated with pallor and lethargy. The child is well in between episodes. Abdominal migraine and idiopathic recurrent disorder characterized by episodic midline abdominal pain in bouts lasting 1 to 72 hours. Pain is moderate to severe intensity associated with vasomotor symptoms. Nausea, vomiting, child is well in between episodes. Benign paroxysmal vertigo of childhood is characterized by recurrent brief episodes of vertigo occurring without warning and resolving spontaneously and otherwise healthy children. Between episodes, logical examination, audiometry, and vestibular function tests are normal. Secondary headaches raise in the great pressure space occupied lesion. Headaches are often raise the fear of brain tumors. This may well be the reason for parents to consult a doctor. Headache due to space occupied lesion or worse when lying down in morning vomiting is characteristic. Headaches may also cause nighttime waking. There is often a change in mood, personality, or educational uh, performance. Other features left in space occupied lesions are visual field effects from lesions pressing on the optic pathway, craniopharyngioma, pituitary tumor, cranial nerve abnormalities causing diplopia, new onset, squint or facial palsy. The sixth abducent cranial nerve has a long intracranial course and is often affected when there is raised pressure resulting in a squint with diplopia and inability to abduct the eye beyond the midline. It is false localizing sign. Other nerves are affected depending on the site of lesion, point time, and lesions may affect the seventh vision, cranial nerve and conservation of palsy, abnormal gait, particular tilting of the head, growth failure, craniopharyngioma, hypothalamic lesion. This is a summary, headache histories. Okay, and papilledema, a late feature, cranial bruising may be heard in AV malformations, but these lesions are rare, early or late. Puberty, change in personality and academic ability, medication overuse, headache. Patients with primary headache, especially migraine, are at risk for developing rebound chronic daily headache, take daily headache on 15 or more days a month. If they had a bad patch and use acute analgesic or triptans on more than 2 days a week, withdrawing the offending medication will resolve this in about 2 weeks. Other causes are listed in that box, which is here. Classification, primary headache, primary tension type headache, cluster headache, and other trigeminal autonomic cephalgias. Other primary headache, secondary headache, headache attributed to non-vascular intracranial disorder, raised intracranial pressure, idiopathic intracranial hypertension, medication, overuse, head or neck trauma, cranial or cervical, vascular disorder, vascular malformation, or intracranial hemorrhage or substance or withdrawal, alcohol, solvent or drug abuse, infection, meningitis, encephalitis, absence, disorder of homeostasis, hypercapnia or hypertension, disorder of facial or cranial structures, acute sinusitis associated with emotional disorders, cranial neuralgia, central and primary facial pain, and other headaches, trigeminal, trigeminal, other cranial neuralgias, essential causes of facial pain, other headaches. These are headaches, this is history, pre-monitory symptoms, aura, character, position, radiation frequency. Duration, relieving exacerbating factors, special configuration triggers, stress, relaxation, menstruation, emotional behavioral problems that can be vision check, corrective error, head trauma, alcohol, solvent, drug abuse, anesthesia overuse. Headache type is tension type headache, obstruction man, bilateral or unilateral pulsatile, nausea, vomiting, abdominal pain, photophobia, phonophobia, lies in quiet afternoon, relieved by sleep. And preceded by aura, visual, sensory, motor, and both tension type of migraine headaches common. Red flag, space occupation headache, worst sign of with coughing or straining headache, wakes up child or young person, different from headache or awakening, not uncommon in migraine, associated confusion, and or morning of persistent nausea, vomiting, recent change in personality, behavior, or educational performance. Red flag, physical signs, space of occupation, growth failure, visual field defects, craniopharyngioma, squint, cranial abnormality, torticollis, abnormal coordination for cerebellar lesions, gait upper motor neuron, or cerebral signs. Fundi is fundus had papilledema, bradycardia, cranial Louis, AV malformation, other physical signs, visual acuity for effective errors, sinus tenderness for sinusitis, pain on chewing, temporomandibular joint, malocclusion, blood pressure from hypertension. Only consider if these red flags features are there. Okay, the management needs to manage oral history and examination with detailed explanation and advice. Imaging is unnecessary in the absence of any red flag features. Efforts should be made to make a specific headache diagnosis. Children or young people and parents should be informed that recurrent headaches are common, that for most there are good and bad spells with periods of months or even years. in the bad cells and that they cause no long-term harm. Written child-friendly question for the family to take home is helpful. Children and young people should be advised on how to live with and control the headaches rather than allowing the headaches to dominate their lives. There is nothing medicine can do to cure this problem, but there is much it can offer to make the bad spells. Medical rescue treatment, the analgesias, and antibiotics, triptans, and physical treatment. Analgesias are paracetamol, NSAIDs taken as early as possible in every troublesome episode. Antibiotics, propofol, pyrazine, or cyclizine for nausea. Triptans are 5-HT1. Sumatriptan, the nasal preparation of this is particularly useful in children and young people early in a migraine attack together with NSAID and paracetamol. Physical treatments such as cold compresses, warm pads, and topical forehead balms. Prophylactic treatment when headaches are frequent and intrusive. Sodium channel blockers, topiramate or valproate. Beta blockers, propranolol, contraindicated in asthma. Cyclic, piezotifen, 5-HT2 antagonist can cause weight gain and sleepiness, or amitriptyline can cause dangerous arrhythmia and overdose. Acupuncture. Psychosocial support, psychological support is there are manageable stressors, bullying, anxiety over exam or illness in friends and family, relaxation and other self-regulating techniques, addressing lifestyle issues, ensuring adequate and regular rest, play, sleep, water. Acknowledge that primary headaches can be extremely painful and incapacitating, even though there is no tissue damage or incipient tissue injury. Seizures is a paroxysmal motor sensory autonomic or cognitive function due to transient brain dysfunction. The term includes epileptic, syncopal, anoxic, brainstem, hydrocephalic, and coning. Emotional, functional, psychogenic, non-epileptic seizures, dissociative states, and as yet undetermined. Regarding seizures as epileptic or non-epileptic, regarding its misdiagnosis of epilepsy, which is common. Okay, so epileptic seizures, what makes a seizure epileptic is the nature of the underlying electrical activity in the brain, especially in the cerebral cortex. So it can sometimes be difficult to tell from non-epileptic, especially syncopal seizures. Clinically, epileptic seizures are due to excessive and hypersynchronous electrical activity, typically in neural networks in all or part of the cerebral cortex. Convulsions and convulsions, seizure, epileptic and non-epileptic motor components, particularly stiff clonic, massive jerk, myoclonic, jerking, clonic, trembling, vibratory, thrashing about hypermotor, as opposed to a non-convulsive seizures with motor arrest and unresponsive stare as in generalized epileptic aphysesis in some focal epileptic seizures, or drop attack as in epileptic atonic seizures. Causes of seizures, epilepsies and epilepsies of brain disorder predisposes the patient to have unprovoked epileptic seizures generally, and epilepsy can be recognized if 2 or more unprovoked epileptic seizures have occurred. Acute symptomatic epileptic seizures, when epileptic seizures are provoked by an acute brain injury from acute cortical ischemia during arterial ischemic stroke, from a cerebral contusion during a traumatic brain injury, or from cortical inflammation during meningitis, they do not constitute an epilepsy even if there were recurrent injuries. They are called acute symptomatic epileptic seizures. The cause of these seizures are listed. Febrile seizures or febrile conversions is an epileptic seizure accompanied by a fever in the absence of intracranial section. These occur in 3% of children between the ages of 6 months and 6 years. This is a genetic predisposition with a 10% risk of the child is a first-degree relative of febrile seizures. Seizures usually occur early in viral infection with temperature rising rapidly. They are usually brief, generalized clinical seizures. About 30-40% have further febrile seizures. This is more likely the younger the child, the shorter the duration of illness. For the seizures, the lower the temperature at the time of seizure, the positive family history. Simple febrile seizures do not cause brain damage. Child subsequent intellectual performance is the same as in children who do not experience a febrile seizure. There is 1 to 2% chance of subsequently developing epilepsy, still with risk of Alzheimer's. However, complex febrile seizure, those who are focal, prolonged, or repeated in the same illness have an increased risk of 4% to 12% of subsequent epilepsy. Acute management seizure is described in pediatric emergencies. Examination should focus on the cause of fever, which is usually viral with bacterial infection to the meningitis should always be considered. The classical feature of the meningitis is neck stiffness, photophobia, not be as apparent children less than 18 months of age. So an infection screen, including blood culture, urine culture, and lung puncture for CSF may be necessary. If the child is unconscious, has cardiovascular instability, lumbar puncture is contraindicated, antibiotics should be started immediately. Parents need reassurance and information. Advice sheet are usually given to parents. Antibiotics may be given but have not been shown to prevent febrile seizures. And the family should be taught the first aid management of seizures. If there is a history of prolonged seizures, more than 5 minutes, rescue therapy with buccal midazolam can be supplied. Oral prophylactic and antiepileptic drugs are not used as they do not reliably reduce the recurrence rate of seizures and have a relatively high risk of adverse effects. And EEG is not indicated as added, does not protect seizure recurrence. Febrile seizures affect 3% children have a genetic predisposition, occur between 6 months and 6 years of age, are usually brief, generalized tonic-like seizures. If a bacterial infection specific meningitis is present, needs to be identified and treated. Advise family about management of seizures. Consider rescue therapy. If simple, does not affect intellectual performance. Complex 4 to 12% risk of subsequent epilepsy. And this is epilepsy with genetics, and the is also but idiopathic caused by alleles as several loci together rather than a single gene, so inheritance is complex. Sexual metabolic cerebral dysfunction, malfunction, cerebral vascular occlusion, cerebral damage, congenital infection, hypoxic encephalopathy, intraventricular hemorrhage, ischemia, cerebral tumor, neurodegenerative disorders, neurocutaneous syndromes, tumors, sclerosis, acute symptomatic seizures due to any cortical brain injury occurred at the time of the trauma or illness, stroke, traumatic brain injury, intracranial infection, hypoglycemia, hypocalcemia, hypomagnesemia, hyponatremia, and hypernatremia. Poisons and toxins for biases in non-epileptic paroxysmal disorder, conversions, expiratory apnea, syncope, blue breath holding spells. Vasovagal syncope often predominantly visible depressors, but can be predominantly cardio-inhibitory, reflex, asystolic syncope, or mixed hypovolemic syncope with hemorrhage, dehydration, or anaphylaxis, cardiac syncope, prolonged syncope. See causes and this is non-epileptic paroxysmal disorder. This is a broad differential diagnosis for children with paroxysmal disorder, funny turns. Epilepsy is a clinical diagnosis based on the history from eyewitnesses and the child's own account. Further videos of the seizures can be graded. The diagnostic question around was it an epileptic seizure? If so, does the child have an epilepsy? Epilepsies can be further delineated as outlined below. Non-epileptic or uncertain further delineation of the nature of the seizure, the paroxysmal event is deployed. The most common pitfall is that syncope leading to anoxic non-epileptic conversion seizures. The key to diagnosis lies in the detailed history review of video if available, which together with the past history and clinical examination will lead to a diagnosis of epilepsy, acute symptomatic febrile seizures, or non-epileptic seizures. Inter-ictal EEG is useful in categorizing an epilepsy once diagnosed. Ictal EEG can be helpful in difficult to diagnose cases when seizures are frequent enough to capture or can be triggered. Transient loss of consciousness is most commonly due to syncope, which is caused by a transient impairment of brain oxygen delivery generally due to impaired cerebral perfusion. Non-epileptic seizure paroxysmal disorder is blue breath holding spells, expiratory apnea, syncope precipitated by anger or crying, or if cannot catch your breath, stuck in expiration, goes blue, stiff and limbs with rapid recovery. Reflex, asystolic symptom reflex and oxy seizure was treated by sudden surprising pain, stops breathing, goes pale, stiff with brief convulsion, sometimes rapid recovery, or a severe sleeps for an hour. Other non-epileptic paroxysmal disorders is called the paroxysmal. Blue breath holding spells, temper, occurs when they are said the child tries, loses her breath in expiration and goes blue. Some children will briefly lose consciousness but rapidly recover fully. Drug therapy is unhelpful. Attack resolves spontaneously, but treating iron deficiency in present may help. Reflex, asystolic syncope, head trauma, cold, food, fright, or fear also called reflex and seizures occurs in infants and toddlers. Many have a first degree relative history of pains. Commonest trigger are pain or discomfort, particularly from minor head trauma, cold foods such as ice cream or cold drinks, fright, fever. After the triggering event, the child becomes very pale and falls to the floor. The hypoxia may induce generalized tonic-clonic seizures. Episodes are due to cardiac asystole from excessive vagal inhibition. The seizure is brief, but the child does not always recover completely. Vasovagal simply children may faint if in a hot and stuffy environment or standing for long periods of caffeine from fear. Chronic movements lasting a few seconds are common. Migraine may sometimes lead to paroxysmal headache involving involving uh, unsteadiness or lightheadedness, as well as the more common visual or GI disturbance. Some young people, these episodes occur without headache. Benign paroxysmal vertigo of childhood, this is characterized with a current episode of vertigo lasting from 1 to several minutes, associated with nystagmus, unsteadiness of even falling. It is a primary headache disorder of children. It should not be confused with benign positional vertigo. Other causes prolonged routine cardiac and prolonged between interval may really cause collapse of cardiac circulation related to exercise. Tics, daydreaming, night terrors, self-gratification. Young children may stimulate their genitalia, pelvic rocking in a high chair, looking preoccupied in order to achieve a feeling of comfort rather than sexual gratification. On epileptic attack, NEAD, functional seizures, medically unexplained seizures, dissociative states, fabricated seizures are fabricated by parent, induced illness, non-accidental injury seizures from hypoglycemia from an adult deliberately injecting insulin. And paroxysmal movement disorder as well, circumscribed episodes, genetically determined, no loss of consciousness. Epilepsy of childhood, epilepsy of childhood. Um, So we are doing epilepsy of child. It's very complex. What is good? Epilepsy has an incidence of about, it's written to there. Epilepsy has an incidence of about 0.05%, less common to first of life, and prevalence of 0.5. This means that most large secondary schools will have about 6 children with epilepsy. Most epilepsy genetically pattern with complex inheritance, but other causes of recurrent and progressive epileptic seizure are listed. And international classification of epileptic seizures by epilepsy is usually used International League Against Epilepsy. This broadly classifies seizures as either generalized or focal. Discharge rises from both hemispheres, includes absence myoclonic tonic spasms, tonic-clonic, atonic, may be in combination or in sequence focal where seizures rise from one or part of one hemisphere. Focal seizure manifestation will depend on the part of the brain when the discharge originates and moves to frontal seizures, whose motor premotor cortex may lead to chronic movements which may travel proximally Jacksonian march or a tonic seizure with both upper limbs raised high for several seconds. Asymmetrical tonic seizures can be seen as very bizarre and hypermotor and can be mistaken for non-epileptic seizures. Temporal lobe may result in strange warning feelings or aura with smell or taste abnormality, distortion of sound and shape, lip smacking, plucking at one's clothing, and walking in a non-purposeful manner. Automatisms may be seen following the spread to the motor cortex. Deja vu feelings are described intense feeling of having been in the same situation. Consciousness can be impaired and seizures are usually longer than absent seizures. Occipital seizures cause a stereotyped visual hallucination. Parietal lobe seizures cause contralatus dysesthesias, and then sensation or distorted body image. Focal seizures, level of consciousness may be retained. Consciousness may be lost, or the seizures may spread to both hemispheres and become secondary generalized tonic season. Many children, especially under 5 years of age, may be unclear whether the epileptic seizure is generalized or focal. The main seizure types are characterized epilepsies. Okay, generalized seizure onset in both hemispheres. Generalized seizures is consciousness of more than 3 seconds duration, no warnings, vertical seizures, bilateral synchronous seizures, discharge, unity, absent seizure, transient loss of consciousness with abrupt onset, termination, and accompanied by motor phenomena except for some flickering of the eyelids and minor alteration. Muscle tone absences can often be precipitated by hyperventilation. Myoclonic seizures weave often repetitive jerky movements of the lips, neck, or trunk. Non-epileptic myoclonic movements are also seen physiologically in hiccups, myoclonus of the diaphragm, or on passage through stage 2 sleep, sleep myoclonus tonic, generalized increase in tone. Tonic will rhythm contraction, the muscle groups following the tonic phases. In a rigid tonic phase, children may fall to the ground, sometimes injuring themselves. They do not breathe and become psychos. This is followed by 20% jerk in the limbs. Breathing is irregular, sinus persistence, saliva may accumulate in the mouth. There may be a bite on the tongue and incontinence of urine. The seizures usually last for a few seconds to minutes, followed by unconsciousness or deep sleep for up to several hours. Atonic often combined with a myoclonic jerk, followed by a transient loss of muscle tone, causing a sudden fall to the floor and drop of the head. Focal seizure onset in neural network limited to one cerebral frontal temporal parietal focals, originated relatively small but dysfunctional neurons in one of the cerebral hemispheres, may be heralded by an aura, the sensory epileptic seizures, which reflect the site of origin. May or may not be so severe change in consciousness or evolve to generalized tonic seizure, focus seizures, frontal seizures, motor trauma, temporal lobe seizures, auditory, sensory, smell or taste phenomena, acceptable positive or negative visual phenomena, parietal lobe, quadrilateral, altered sensation, dysesthesia, some of this syndrome arranged by age of set. These are infantile spasm, Lennox-Gastaut syndrome, and child absent epilepsy. These are given very good in this. And we'll discuss this one by one. And I guess we can discuss this later because this is very, very important. Yes, we can do this later. And then we'll do motor disorders. And then all the motor disorders are very, very okay. We'll do all of this later. Thank you very much. Thank you.